What's up? I'm Hutch, and you need to learn about shoulder impingement so that you can better evaluate and also treat your patients, and also pass the NPTE. So let's talk about impingement. There are a few different types of impingement that all look pretty similar, and so it's up to you to first of all figure out the root cause of the problem, and second of all figure out a way to treat this patient for their root cause and not just slap on a cookie cutter routine because you hear the word impingement. The most common mechanism for shoulder impingement is overhead activity that's repetitive, especially involving abduction and external rotation. So you can see this in athletes or people who spend the whole day changing light bulbs overhead. There are three main types of shoulder impingement. The first one we'll talk about is external primary subacromial impingement. External means that it's just outside of the glenohumeral joint. Primary means that it's something structural, something that's typically genetic or due to a previous injury that you can't really fix. Subacromial means it's under the acromion, and impingement means that something is pinching. So basically what happens is there's some kind of stenosis in the subacromial space. Genetically, you can have different curvatures to that acromion, and type 3 curve on that acromion will cause decreased space naturally. You can also have poor healing after a fracture. You can have bone spurs, things like that, that'll decrease that space naturally in a way where there's nothing really that you can do to change it. Now, with that anatomical change, plus the overhead repetitive movements, the supraspinatus, which runs underneath the acromion, will rub against that acromion and get irritated and inflamed, and that's where a lot of your pain will come from. This type of impingement is more likely in people who are older, so like 40s, 50s, or above, who have symptoms like degeneration, weakness, disc problems at the acromioclavicular joint, poor posture, or bone spurs, all of which can decrease the subacromial space. For both types of external impingement, you'll note that symptoms are typically superior and anterior on the shoulder, with possibly some referral to the deltoid insertion due to rotator cuff involvement. The second type of shoulder impingement is external secondary impingement. External, again, meaning that it's outside of the glenohumeral joint, and secondary, meaning that it's not genetic and it's related to something else. Now, this is typically also subacromial impingement, but I'll talk a little bit later about another variation of this impingement that's not necessarily subacromial. The other thing to notice is that this impingement is mostly functional. So type 1 is structural. This is a functional type of impingement. So let's talk again about the subacromial space. That acromion actually forms about half of this bridge or this arch, and the front half of that bridge is formed by ligaments, and the supraspinatus runs right underneath that bridge. Now, with this repetitive overhead movement, especially if the mechanics are really poor or there's some kind of muscle imbalances, you can have a couple different problems that occur. First off, you can have increased strain to that rotator cuff, aka the supraspinatus. You could also have the humerus actually moving anteriorly due to shoulder instability. As that glenohumeral joint moves anteriorly, that supraspinatus is actually going to rub up against those ligaments. Either way, you're going to have the same effect where there's decreased space there. That supraspinatus is getting really inflamed and irritated and causing a lot of pain. Now, that other complication that I was talking about involves the subscapularis. Now, this is another rotator cuff muscle whose tendon is actually anterior to where the supraspinatus tendon is. And with those poor throwing mechanics, something similar can happen here where that muscle and its tendon are rubbing up against the coracoid process and getting inflamed and irritated and decreasing the space there. Either way, you'll have this anterior, superior shoulder pain and irritation. This is a little bit more likely with shoulder adduction rather than abduction in sports like tennis where you're hitting something across your body. And if this is severe enough, you can have what's called a Tufts tear to that subscapularis. This type of shoulder impingement is much more common with younger athletes, so people that are involved with baseball, volleyball, swimming, anything with that repetitive overhead motion. The pain will be superior and anterior, and depending on severity, can happen just during activity. It can present in a painful arc pattern, or it can be painful at night and after activity, but it will usually go away if the shoulder's in a relaxed position just at your side. The last type of impingement is internal shoulder impingement, aka posterior superior glenoid impingement. This is impingement at the glenohumeral joint itself, and usually in the posterior aspect. Similar to the last type of impingement, this internal impingement is often a result of those poor repetitive overhead mechanics, but in this case you have the greater tuberosity of the humerus, which repeatedly hits against the back of the glenoid. This can cause a lot of different issues, and let's talk about anatomy to understand why. If you remember, the glenoid is pretty flat, almost like a dinner plate, so it's got a slight curve to it, but not quite enough to keep that humeral head inside. And so instead, it has this soft labrum that goes around the edges to kind of make that plate into more of a bowl shape to keep that humeral head inside. If the greater tuberosity of the humerus keeps hitting against the edge of that glenoid, you're going to have tearing at the labrum, possibly something like a slap tear. You can also have issues with the biceps tendon since that attaches to the labrum as well. So if the labrum and the glenoid are injured, you can have a lot of instability in the biceps as well as just in the shoulder joint itself. Secondly, the area that this injury is occurring at is right next to two rotator cuff muscles. Anteriorly, you have the supraspinatus tendon that comes in, and posteriorly, you have the infraspinatus tendon that comes in. So if that injury, moves a little bit forward or backwards, you can have tearing to one of those rotator cuff muscles as well, even something as severe as a POSTA injury. The profile of these patients is pretty similar to the last type of impingement we talked about. A lot of overhead athletes, weightlifters are a little bit more involved in this category, except that the pain is going to be more posteriorly located than with the external types of impingement. Another symptom that these patients might have is a popping or clicking sensation, especially if that labrum is involved. Every time you move, there might be a noise or sensation of that variety. So basically, those are the three types of impingements. Those are your options for what can happen if you have poor overhead or throwing mechanics and you do it all the time. So another thing to look at really quickly is categories of severity that Neer created. Level 1 is usually younger people who have reversible swelling and pain during overuse. Level 2 is a little bit older and their injury develops into fibrosis. They don't have tears yet, but they do have scar tissue that may be involved, as well as pain during normal daily activities and at night. Level 3 are small tears and level 4 are larger tears, and these are both more common in older people whose rotator cuffs are pretty weak and overused over time. So with all that in mind, it's still pretty tricky to figure out in an evaluation exactly what's going on. You can kind of get a general idea, but there's a lot of things that may be involved. So I wanted to talk really quickly about how to evaluate and a few different key contributors that you may want to take a look at. So of course you'll want to look at the patient profile. Are they an athlete? What type? How old are they? You'll want to look at their pain profile. So the location, severity, duration of symptoms. Are they acute or chronic? What are aggravating or relieving positions or movements? Check out their posture. Do they have forward neck, thoracic kyphosis, rounded shoulders? Is their dominant arm bigger or does it hang lower than the other side? All of these can also contribute to poor mechanics. You'll want to do some manual muscle testing in the cervical region, as well as the rotator cuff and scapular stabilizers, especially the serratus anterior, traps, and rhomboids. You'll want to look at their capsule mechanics, especially if they have some kind of instability or poor mechanics over time. Frequently, they can have a loose capsule anteriorly and a really tight posterior capsule. You'll also want to look at movements for the AC and SC joints. Scapular dyskinesias can also be a big problem, so check out if they have winging, painful arc, again, muscle imbalances left to right, as well as the bigger muscles compared to the rotator cuff. You'll want to do a functional evaluation, so throwing or lifting. Do they have proper neuromuscular control and muscle recruitment during that activity? If they're a pitcher, you'll want to look at weaknesses in their balance and plant legs during the throw, as well as humeral versus scapular position during that throw. Then you have your special tests like your impingement cluster, your labral tests, your biceps tendon tests that can kind of confirm what you have already figured out with all of that other testing. So like I said, it's really good to understand what structures are actually involved, but you also have to understand what are the mechanics, what are the contributors that are causing those structures to be painful and inflamed. What are the aggravators? And those are the things that you can fix in physical therapy. Now it's time for NPTE Jeopardy! Pause the video now if you want time to read and think about the question. Otherwise, you've got 5, 4, 3, 2, 1. The word functional here should clue you in pretty well to this type of impingement. Primary external impingement will be more structural rather than functional, and internal impingement will be more posteriorly located than the supraspinatus and acromion. That should cover all of our bases. If not, you can always check out the description box below for a link to my notes on Etsy, or you can comment with questions or suggestions for videos I should do in the future. Otherwise, good luck studying. Go change the world. Shout out to Sachu Krishna on Etsy for the request for this video.